Shall we start?
Now, you can start. Hello?
Yeah.
You can start the session, sir.
Okay. Once you say go ahead, I'll start the session.
Sir, you can start. You go ahead, sir.
Yeah. Good evening, everyone, and a warm welcome to this session on arrhythmias and stroke, which is a very important current hot topic. I'll describe to you the reasons why it is a very important topic, and we see stroke patients day to day, and also they have cardiac problems. This is a double whammy, as I'll show you. So today I'll be talking about arrhythmia and stroke, a double whammy. What do we mean by this double whammy? How it causes double jeopardy to the patient? That is the talking point of the day. And we'll try to see how to recognize this problem and how to prevent it, because stroke, as we know, is a very devastating disease, very disabling disease, and affects the quality of life very significantly. It's a very kind of life-changing disease. If there is a stroke and patient becomes dependent, it is kind of removes him from his job. It becomes economic burden. He becomes a burden on the family as well as the society. So it's very important to prevent a stroke rather than treating a stroke after it occurs. Strokes and atrial fibrillation both have an increasing trend. That's why it is a hot topic. And as the population ages, the world over, the population is aging as the life expectancy is increasing. With each decade of life, increase in life expectancy, atrial fibrillation increases by 1%. And the overall incidence of strokes also have increased because of the lifestyle diseases like hypertension, diabetes, atherosclerosis, and recently COVID has added to the woes of patients developing more and more strokes. We have seen a lot of strokes during the first and the third waves of COVID. And why this association becomes doubly dangerous? Arrhythmia and stroke carries 10 times higher mortality than stroke alone. If patient has a stroke with a sinus arrhythmia, sinus rhythm, they tend to do better, whereas a stroke in combination with an atrial fibrillation, they tend to do worse in terms of mortality, morbidity, severity of stroke, recurrence of stroke. All these parameters are worse in patients with arrhythmia and stroke. That is why it is very important to understand this relationship and how we can mitigate this disastrous complication. Recognition is very important because it is highly preventable. We can prevent strokes occurring due to arrhythmias in a majority of cases. If we look at them carefully, we can prevent the first stroke, and then if we take pay enough attention to the risk factors, give them anticoagulation, control their rhythms, we can prevent a recurrent stroke. Underlying cardiac condition determines the outcomes and recurrent events. Suppose they have severe left ventricular failure or a cardiac condition which predetermines their clinical condition, that determines the outcomes of stroke. It is not that stroke is a disease in isolation. It arises from the soil of atherosclerosis, hypertension, diabetes, various risk factors for stroke. Many of them are in common with a heart attack. That we'll discuss in the next slide. So strokes and heart, like I said just now, is a vascular continuum. It's a vascular disease. That's why we call them as cardiovascular diseases, cerebrovascular diseases. Many of the factors are very common between them. Atherosclerosis and atheroembolism are terms we should understand more clearly. The risk factors are, as I said, are very common to both the illnesses, cardiac illnesses and stroke. The pathophysiology is also similar. Like in embolic stroke, there is a clot which is obstructing the brain circulation. In a myocardial infarction, there is a clot which is superimposed on a ruptured atherosclerotic plug or an ulcerated plug, which has caused occlusion of the coronary arteries. So the pathophysiology, the incidence, the risk factors are very closely shared by cerebrovascular diseases and cardiovascular diseases. And thereby the treatment is also very similar. If you see a stroke patient's prescription and the prescription of a patient with a heart attack, they're very similar in terms of statins and dual antiplatelets, high-dose statins, the use of other agents to reduce LDL, and the risk factors are common. So the prescriptions almost run in parallel with each other. So what is this association? We'll try to briefly examine what is the association between arrhythmias and strokes. There are innocent arrhythmias, for example, sinus arrhythmia, which is the commonest kind of arrhythmia in human beings, which is nothing but a respiratory variation of heart rate. Arrhythmia, a complete regularity of rhythm indicates autonomic dysfunction, and these patients are more prone to sudden cardiac deaths and maybe strokes also. Benign atrial ectopy, when there are few ectopics here and there, they are pretty common. And if you do a Holter recording 24, 48 hours or 72 hours, we commonly see these ectopics. They are of no consequence if there are no associated diseases, but they may also be a precursor of atrial tachycardias and atrial fibrillations, which we will see shortly. Benign ventricular ectopy may not be so benign, but unifocal ventricular ectopics in the presence of a structurally normal heart. The treadmill is negative, there is no ischemia precipitating, there is no secondary cause, there is no electrical abnormality in the heart. Those are called as benign ventricular ectopics, and they do not by themselves cause any disease. So what are the culprit arrhythmias? The most important culprit arrhythmias in stroke is paroxysmal atrial fibrillation and permanent atrial flutter and fibrillation. So this is what is our attention for the day today. Paroxysmal and permanent atrial fibrillation both have the same incidence of stroke. This is one thing we have to understand, because both the plants arise from the same soil. The risk factors are the same: atrial enlargement, high atrial pressures, atrial appendage clots. They are all very common to both these conditions. So paroxysmal AF and permanent AF carry the same risk of stroke. And when we see paroxysmal atrial fibrillation, we should treat it in the same way in terms of indication for anticoagulation as permanent atrial fibrillation. So that point has to be carried on. It's a very important point. So what are the rare culprits in the heart which can cause stroke, but they are not the common causes? Extreme bradycardia, we know very severely low heart rates like 40 or 30 beats per minute, very, very long pauses can cause syncope or pre-syncope like episodes, but not really the strokes. But in patients who have, in addition, carotid atherosclerosis, cerebrovascular atherosclerotic disease, they can lead to what are called as watershed infarcts. That is, not enough blood is reaching the cerebral circulation. So they might have micro brain infarcts. Of course, we are all familiar with stroke attacks occurring because of carotid disease. TIAs and strokes can occur. The rapid hypotensive ventricular tachycardias and flutters, they can cause low cardiac output strokes, but they commonly occur in association in the setting of MI. Stroke and MI can occur together, but the tachyarrhythmias causing strokes are less frequent as compared to atrial fibrillation. So our focus point is basically atrial fibrillation, both paroxysmal and permanent. So what is the mechanism underlying arrhythmias and stroke, especially with respect to atrial fibrillation? Dilated immobile atria. We know that whenever a clot has to form in a cardiac structure, heart is a moving structure which is in continuous motion, at least 60 times in a minute it beats. So it takes the blood to be in stasis. That means a part of the ventricle is infarcted, there is an immobile segment and blood stasis is there leading to clots. Or there is a chamber where there is no effective contraction. That is what happens in atrial fibrillation. In atrial fibrillation, there is no effective contraction of the atria. Atria are getting stimulated at a rate of 300 to 600 beats per minute. The electrical activity is there, but there is no effective contraction, which leads to stasis of blood in the atria, especially the left atrial appendage, which leads to thrombosis. And these microemboli move to the brain and cause strokes. That is the main mechanism. So there is a relationship between left atrial mass, left atrial volume, and contraction relationship, which I just spoke about. Left atrial appendage velocity, that is the velocity of blood flow at the mouth of the left atrial appendage, is important. When it is reduced, It leads to blood stasis, left atrial smoke, what we call the swirling of the blood there, stasis, which are precursors of thrombosis, and then, of course, embolism. Almost about 30% of all strokes are due to cardioembolic. They occur as a result of emboli arising from one of the heart chambers or the valves. So what is this stroke arrhythmia sequence? Does stroke occur first, or the arrhythmia occurs first, or what happens? Did the egg come first or the hen? The association, whether it is causative, whether this arrhythmia caused the stroke, or both, since both the vascular factors are there, the cerebrovascular, cardiovascular factors, the underlying soil and the seed is there, the stroke disease arises out of that. Or is it just an incidental association? Like we see in many of the strokes, there is sympathetic stimulation, which leads to runs of atrial tachycardias and sometimes paroxysms of atrial fibrillation. Then the causative association becomes difficult to make. We also know that there is increased adrenaline and sympathetic surge whenever the patient has a stroke, which leads to STT changes on the ECG, commonly sometimes mistaken for myocardial ischemia and sometimes infarction also, which is a result of the sympathetic surge. The same can cause some of the arrhythmias. So especially in the initial period of stroke, in 24 to 48 hours after an acute stroke, some arrhythmias are found on the Holter. So how do we recognize this? How do we recognize that patient is having an underlying arrhythmia? Now, as per the current recommendations, every patient with a cerebrovascular event, irrespective of the age, should undergo cardiac monitoring, some type of cardiac monitoring. It started with continuous ECG monitoring. The initial interest was in the arrhythmic runs and ST changes, but of course, we soon realized that we are basically looking for this particular condition called atrial fibrillation, which may be paroxysmal or permanent, which showed a very consistent association with strokes. In stroke patients, the longer you monitor, more number of patients will have atrial fibrillation. If you, on day one, if you monitor about 2.5% of the patients show atrial fibrillation. If you prolong the monitoring to 72 hours, 96 hours, in the recent guidelines, people are monitoring them with a continuous implantable loop recorders for up to a few years. And with the prolonged monitoring, the incidence goes on increasing. So then you have some kind of a epidemiological or an associative finding, and then you can anticoagulate these patients. Why is it important to recognize? Because we can treat these patients, we can prevent subsequent occurrence of a stroke. That is why it is important. So longer the monitoring, higher the yield. Advances in remote monitoring have increased monitoring time from 24 hours to several weeks to months. Now we can monitor with implantable loop recorders for up to several years, 4 to 5 years. You can monitor the patient, especially in cryptogenic stroke, where cryptogenic stroke is where you have not found any cause. Patient does not have any obvious cause. Some of them might be patent foraminovarus, which where the thrombus is coming from the right side, from a venous thrombosis or whatever side, or from an occult arrhythmia, like atrial paroxysm of atrial fibrillation comes, causes stroke, and then it disappears. Then it is not detected at all. Now we have several advanced devices. Earlier we used to have a gigantic, large things which had to be tied to the patient's body. Now we have very sleek patch electrode-like devices. If you see here, this is one of the patches which we use. This is just placed on the chest. It can monitor the patient anywhere from 72 hours to up to a week, depending on the capacity memory of this particular chip. It also is SIM based, and once the patient wears it, it's connected to the smartphone, and daily 2 times this device will update the patient's rhythm to the patient's own mobile phone, which we also can access to our emails. And once the period is over, patient does not even have to return to the hospital. He can just discard his patch and will get all the online alerts, and there is a call center which continuously monitors the rhythm. We'll get alerts for any arrhythmias, and also the physician will get the final report so that he can see it even in the absence of the patient. That is how advanced now remote monitoring has become, especially useful after the advent of COVID, when patients were reluctant to come to the hospital but continue to have arrhythmias or at risk for stroke. And these were very useful at that time. Just put a patch and tell the patient to go home, then have a video call or a telephone consultation and advise the patient accordingly. So this is one such recording which is showing in the same patient, a supraventricular trigeminy. You see the atrial ectopics, some runs of ventricular ectopics, and also the paroxysmal atrial fibrillation. There is a run of atrial fibrillation, fast, irregular, narrow. That's how you recognize atrial fibrillation. Fast, narrow, and irregular. So there are also now home-based devices. This is one such devices which is available. You can easily get it from the internet. It is a device where there is a patch like this. You just place your thumb or two of your fingers. You can get an instant ECG which can be saved. It has a reasonable single lead, good quality ECG for measuring, for observing the rhythms, and this can be saved and immediately transmitted to your physician. So an immediate diagnosis is possible whenever the patient is having an episode of palpitation or some symptoms. It can be immediately done and carried around by the patient. Not very expensive, around $100 or so, available on the internet, including Amazon. So this is one more such device, a medical grade cable-free extended ECG rhythm monitor. All these devices, you see, this is a regular smartphone. This is a device attached to the chest, and it can read the rhythm, and the same rhythm can be stored as a picture, and you can share with your physician. Patient can share with the physician. So those are the kind of advances that have come now. So monitoring has become pretty easy. Earlier, monitoring used to be very cumbersome. Patient used to have to carry the device all the time, wear multiple leads with so many wires on the chest, and so on and so forth. There are so many logistic problems with that. So now it has become very much easier with the advent of smartphones and very portable devices. So once you have detected this, how do you prevent stroke? Main thing is the attention to risk factors, which I was talking about. Smoking, a very common risk factor in our country especially. Quitting smoking certainly helps in reduction of the stroke volume. Hypertension, control of high blood pressure, diabetes, dyslipidemia. There has been a recent emphasis on measuring and controlling LDL, low density lipoprotein, and the new LPA molecule, which also has been associated with disease in multiple vascular territories. In fact, now, if we see a younger patient below the age of 50, we investigate them for high lipoprotein A. There is an association between high lipoprotein A and heart attacks and strokes. So these patients we treat more aggressively. Now we have a multitude of drugs to treat these conditions, including evolocumab, inclisiran, which very significantly lower the LDL to levels which we couldn't imagine earlier. We now reduce the LDL to say 30 or 40 to the fetal levels, whereby there is a definite improvement in the incidence of recurrent strokes. Of course, the non-conventional risk factors are there, including hyperhomocystinemia and or if you don't find a conventional risk factor, patient has an occult stroke, we investigate them, especially if patients are below the age of 50 years. We also look at the interatrial septum. If there is a patent foramen ovale, patient with an occult stroke needs that PFOs to be closed because there is some causative association between a patent foramen and occult strokes. So then we classify them according to this scoring, which is the universally accepted and the most widely used score, which is called as the CHAD-VAS2 score. If they have congestive heart failure, hypertension, age more than 75, diabetes, stroke, vascular disease, age greater than 65, and females, they all get points according to this. If the score is 0, no therapy or only aspirin if they have additional risk factors. And if the score is 1, aspirin or oral anticoagulation, and oral anticoagulation is preferred, of course. And if the score is greater than or equal to 2, definitely oral anticoagulation. Oral anticoagulation has come to the fore in the therapy of stroke prevention, and of course everybody should be aware of it. It has become now the standard of care. In fact, if you see a patient with a high CHAD-VAS score and you haven't given anticoagulation, it becomes a violation of the standard of care. So in atrial fibrillation, like I said, whether it is paroxysmal or permanent, the risk of stroke remains the same. And it's a class 1 recommendation for giving anticoagulation, which is the summation of evidence from several randomized clinical trials comparing anticoagulation versus placebo. There was comparison between single antiplatelet and oral anticoagulation, dual antiplatelet and oral anticoagulation. And in every known study, giving anticoagulation turned out to be superior in terms of reduction in stroke. with equal or lower incidence of bleeding in some cases. All patients must be anticoagulated. There is no excuse. We cannot give excuse saying that the patient is too old, for example. In one of the trials, it was shown that even patients above the age of 80 years, if you carefully assess them for their bleeding risks and give them anticoagulation and follow them up very carefully, those patients did better. And some of them have the question, this next question will come, whether dual antiplatelets is enough. I don't want to give an anticoagulant. Shall we give only aspirin and clopidogrel, which has proven beneficial in acute coronary syndromes and strokes? But no, anticoagulation is better by a very significant margin. Dual antiplatelets increase bleeding risk significantly without much gain in stroke prevention. So this is one important lesson. So you should not use dual antiplatelets as treatment for prevention of stroke. If patient has coronary stents, then give dual antiplatelets for a recommended period of time. Then if they are in AF, convert it into a single antiplatelet and give oral anticoagulation. That is the therapy that we follow today. So the conventional versus the new agents with respect to anticoagulation, this has been a debate which is now settled. For the past decade, it has been going on, but now we know that the newer oral anticoagulants are better agents. They are significantly better in terms of stroke reduction. Also the bioavailability, less interaction with food. There is no need for monitoring these patients. The conventional vitamin K antagonists require regular monitoring, and the time the patient remains in a therapeutic ratio is very low for the conventional agents, and there are more bleeding risks with them, especially the intracranial bleeding seem to be lesser with dabigatran in the dabigatran studies. So these are the few agents that are right now available. In addition, there are several new agents coming up, including edoxaban, and some of the drugs are also undergoing active clinical trials currently, including our center. Dabigatran, rivaroxaban, and apixaban have a lot of cumulative evidence over the past decade and a half with respect to how we anticoagulate patients with atrial fibrillation. Of course, there are other therapies like surgery when we know that left atrial appendage is the source of the clot. Left atrial appendage excision, especially when patient is undergoing some other cardiac surgery like CABG or valve disease, if the surgeon finds an opportunity to open the chest, the left atrial appendage should be removed, just like the surgeons remove the appendix, which has no known function. Removing the left atrial appendage seems to confer the advantage that this particular patient may have freedom from embolic stroke from the left atrial appendage. Of course, people have tried video endoscopic ligation of LA appendage, which as an isolated procedure may not be recommended because of the morbidity associated with the procedure itself and the cost. But if patient is undergoing some procedure along with that, the LA appendage should be excised. There are left atrial appendage exclusion devices when patient has a significant risk of stroke or already has had a stroke and has atrial fibrillation and cannot take anticoagulation. Left atrial appendage exclusion devices are now available, which can be safely performed. You put a plug into the left atrial appendage so that no clot comes into the body of the left atrium, so there is nothing to get embolized. So these are the few therapies briefly that I could describe. And the take-home messages, recognition is very important. Stroke and arrhythmia association. Extended monitoring. Like I said, if you just do a 24-hour Holter, you may miss a patient and think that he is in sinus rhythm and may not give anticoagulation. But when you extend the monitoring to say 72 hours and further, in case there is an occult stroke or a cryptogenic stroke and the suspicion of arrhythmia is high, in fact, there is a study going on where they are putting implantable loop recorders for years together, for 4 years. And they found that with increasing period of time, more and more detection occurs with respect to atrial fibrillation, and these patients can be anticoagulated and further strokes can be prevented. Of course, control of risk factors, including, I would like to briefly mention the COMPASS study here. If patient has multiple risk factors and you suspect disease in 2 vascular territories like myocardial infarction and a TIA or stroke and on the base of atherosclerosis, should consider them for low dose anticoagulation. Addition of rivaroxaban 2.5 milligram twice a day help these patients reduce stroke by 48%. An amazing percentage of patients had lesser number of stroke was prevented. So in those patients in sinus rhythm with multiple risk factors and evidence of atherosclerosis in 2 vascular territories, consider low dose of rivaroxaban at 2.5 milligram twice a day. But if they have atrial fibrillation, then give the atrial fibrillation dose, which is like 15 milligram or 20 milligram of rivaroxaban, or dabigatran 110 milligram dose for the patients with lower creatinine clearance. And if patient's normal creatinine clearance, it is 150 milligram twice a day. Of course, if they fall into the group of mild CKD, where the eGFR remains at around 60, 45 to 60, you consider apixaban with the lower dosage. And below 30, of course, the conventional vitamin K antagonist should be used, and Novax have still no evidence in that particular group of patients. So anticoagulation is standard of care for atrial fibrillation. So that is the message for the day. Thank you all for the patient hearing, and I'll be happy to answer any questions related to this. It's quite an extensive topic talking of stroke and arrhythmias, but I think I've briefed you about how to monitor, recognize, and treat these patients. Thank you all.
Hello.
Yeah.
Hello.
Yeah. Any questions?
Sir. Yeah, there are some questions are there. We'll post one by one the chat.
Sure.
Sir, posted the first question.
Yeah, what is a long-term prognosis of a child with a heart arrhythmia? It depends on what kind of arrhythmia, Dr. Saurabh. If it is like a paroxysmal supraventricular tachycardia, which occurs commonly in children in the presence of a structurally normal heart, it can be permanently cured with a simple procedure called EP study and RF ablation. And 99% of the times, patient can be completely cured. So arrhythmias in children with a structurally normal heart, so-called structurally normal heart, they are curable. But of course, if you're thinking of arrhythmogenic right ventricular dysplasia or some kind of very malignant arrhythmias, they have to be treated with an ICD, and that also gives a fairly good prognosis for these children. The role of genetics in etiology of atrial fibrillation, especially there has been a recent resurgence of interest in the genetics of etiology, and there are several trials going on to prove that there is a genetic association for patients with atrial fibrillation. But therapy-wise, nothing has come out. So we control the risk factors. We control the soil so that the seed of atrial fibrillation doesn't sprout in that soil. So it is more of control of risk factors like hypertension, diabetes, preventing the dilatation of atria, reducing the left atrial volumes, assessing the left atrial appendage, and wherever possible, treating this condition. So certainly, there is a genetic association of atrial fibrillation. Which findings of a head and neck exam for atrial fibrillation suggest an increased likelihood of comorbid coronary artery disease? You can palpate the carotid. The initial association of coronary artery disease and carotid artery disease is known. We used to assess carotid intimomedial thickness as a measure of risk of stroke. But now the scene has shifted. Iliofemoral disease, that is disease in the iliac arteries and the femoral arteries, seems to be more predictive, more than actually the carotids. So we have moved on to peripheral examination of the peripheral arteries. If there is intimomedial thickening or there is some evidence of atherosclerosis in other territories, it's quite significantly predictive of cerebrovascular disease.
Hello.
Yeah,
sir, we are done with all the questions now. And thank you very much, sir, for your valuable time and sharing the important insights on the topic, sir, in a very good and executed manner, sir.
Thank you. Hopefully it was useful for the participants, and if they take home that message of stroke prevention in atrial fibrillation, that will be very successful for me. Thank you.
Okay, sir. Thank you very much, sir.